You're listening to Three Makes Baby, a podcast about fertility, family, and genetics. I'm Jana Repnow, a fertility counselor and author of Three Makes Baby. Welcome to the show. Hey, everyone. It's a special episode of the Three Makes Baby podcast with a return guest, actually, Diane Tober. You may have remembered her if you've been listening for a while. Dr. Diane Tober is a associate professor at the University of Alabama. She is a medical anthropologist and studying egg and sperm donation, specifically donors, and has written a book that is called Eggonomics.
Mhm.
This is the global market in human eggs and the donors who supply them. So we get to hear from, it's quite an honor to hear from you today, Diane, and the research that you've done on egg donors, which is really one of a kind. So can you tell us a little bit more about what is a medical anthropologist? I don't know that I don't really fully know what that is. So
Yeah. Well, and first of all, thank you for having me. I'm glad to be back here to discuss this work. And yeah, so basically, in a nutshell, a medical anthropologist looks at the same kinds of things that cultural anthropologists look at, which is contemporary culture and people's perceptions and beliefs and practices surrounding health and illness. So you might have somebody, for example, go study HIV/AIDS in Africa and look at, how people think about and stigmatize infectious diseases, for example. One of my former advisors, Gay Becker, she wrote one of the first books on infertility. She did a study on gender differences in response to infertility. That was back in the early 2000s. And she and other medical anthropologists, for example, Nancy Shepherd Hughes, another mentor, she did work on hunger and mothering in Brazilian shanty towns. So anything that connects with individual and social health, the surrounding environment, cultural beliefs and practices, that kind of thing.
Okay. That's fantastic. And what brought you to the field of donation conception?
Yeah, well, my earlier work actually with Gay Becker was since she had a project looking at gender differences in response to infertility. At the time, a lot of single women and lesbian couples were calling up to volunteer for the project, and they were being turned away because they did not meet the criteria of being a heterosexual married couple. That was back in the 80s and 90s, where infertility, the definition of infertility was trying for a year or more through unprotected sex to conceive and not being able to. And so single women and lesbian couples obviously fell outside of that. Well, especially lesbian couples fell outside of that criteria. And so these women were calling up to volunteer for the study, and they were being turned away. And most of them were using sperm donors, obviously, to create their families. And so I saw an opportunity to not only let people who want to share their stories, but also to turn that into a dissertation project. And that ended up leading to my first book, Romancing the Sperm, looking at how biopolitics and the making of modern families, and looking at sort of the intersections between single women and lesbian couples using sperm donors, and how they thought about their what they do as a kind of reproductive work, so to speak, and sexuality surrounding, being controlled within the walls of the sperm bank, and then at the larger level, how sperm banks operate. And at the time, most people could not access donor sperm through most sperm banks. There was only one at the time that provided access to single women and lesbian couples in the Bay Area. That was called the Sperm Bank of California.
Yeah.
And then the larger, broader political environment surrounding alternative, what at the time was called alternative families. Now we say, well, alternative to what? But at the time, the people that were using sperm donation, single women and lesbian couples that were using sperm donation to create their families, that was sort of outside the parameters of, what again at the time was considered to be the heteronormative standard of, a married couple, nuclear family, that kind of thing.
Mm-hmm.
So I was very interested in the politics of family and how that intersected with individual practices and what's available.
Okay. Yeah. So biopolitics is kind of what you said. It's like the politics of family, but what's the bio part? Is the bio part reproductive?
Biological production.
Yeah.
Yes, exactly. Yeah. And, for example, some of the things I talk about from a theoretical perspective is how we think about what genetic material means. So,
Yes.
so how do people, for example, women that don't have male partners, how did they choose sperm donors based upon their own individual set of values and priorities? So people might want somebody, tall over somebody short. They might want somebody who's a doctor over somebody who's, a student at a community college. So there's how people think about what they want to reproduce. So that sort of eugenic component
Yeah.
even comes into the everyday practices that individuals use to create their families.
Yeah.
And there's still, it's sort of like, I call it grassroots eugenics, but there's still eugenic overtones, but without that loaded, with the little less loaded notion of eugenics, the
Yeah.
larger scale.
Yeah. So we're using a lot of big terms. So eugenics is basically the practice of sort of controlling how a person looks, like their eye color, their
Race.
height, their race,
Yeah.
and that is not it's a practice that can, has a lot of controversy and has a lot of problems, but also it is something that is being done too, and not necessarily purposefully by recipient parents. They're not
Right.
doing it to cause harm. They're not doing it on purpose. They're doing it because it's like you said, it's how we think. It's how we like it. We are attracted to people like us that look like us and behave like us. So there's that's part of it. So what's really, I think, struck me in your work is that the attention that you've paid to egg donors, because I just don't see many people paying enough attention to women who are helping other people have families by donating their eggs.
Mhm.
And there's just so much we still don't know. And what I was really excited to see your book come out, just to be able to dive deep into it. I was struck by one of the first stories you shared, which was of you, and I believe you were in Spain, and you were in the room where they were doing the procedure to retrieve the eggs from an egg donor.
Yeah.
And it was so visceral, like the senses and the way that you described it. I really I saw myself there. I saw you there. It really created a picture, but it also I never thought about it. Even this, having done this work for so long, I've never thought about that from that perspective of what the egg donor, what she was going through in that moment, and what position she was in, and the vulnerability that she was in. And it really hit me hard. Can you describe a little bit about, sort of that moment, and what, maybe give us some insight as to what struck
Right.
you in that moment?
Yeah, well, I'll backtrack just a little bit and and mention that I've been conducting research with egg donors now for 10 years, since 2014. And prior and I was really interested before going to Spain in sort of how US policies and regulations surrounding egg donation and Spanish regulations are completely different. There's no real regulations in the United States, or they're very inconsistent, whereas Spain has a more regulated system. And I was really curious if this more regulated system was, better for donors' experiences. And then before I went to Spain, I had interviewed probably close to 100 or more at the time US egg donors and other egg donors from around the world. And Josefina, the one I opened the chapter with, she, she was that was the first case where I was actually in Spain in 2000, I believe, 19. And, one of my first days of field work in Spain, where I was able to observe in a clinic. And I had heard a lot of people's experiences before. I've heard some, the whole range of experiences from positive to, catastrophic.
Yeah.
And but being in that room for the first time and seeing this young woman come in, and her very beautifully manicured hands and sort of like, she was really, I could tell she was like scared, nervous. She was being guided to the bed by the nurse, but nobody was really engaging with her and talking to her and telling her, oh, you're doing a great job, you're doing a great thing, and encouraging her. It was just sort of mechanical.
Yeah.
And then that moment when she laid down and the anesthesia took effect, I could sense an immediate shift in her presence in the room. It's like, it almost felt, I mean, it almost went from even though she was alive and she was fine, but
Yeah.
just being in that room and just feeling sort of like what I felt in that room, it was almost as if she had transitioned from a life full body to a lifeless body. You know,
Yeah.
it didn't feel real anymore once she was out.
And that
And
must have felt like she's in this vulnerable state now, and she's in this state where there's nothing she can do.
well, I mean, for me, not having ever seen the surgery like that from the outside before,
Hmm.
for me, I really I had to struggle to stay connected to her humanity
Okay.
because
Okay.
I started to see her in sort of an object-like status, right?
I see.
And so, and that's why in the introduction, I focus on her fingernails, her
Mm.
recently manicured fingernails, because I could create a scene in my head of her talking to friends, going with friends to get a manicure, having a beer. I was trying to connect to her life
Yeah.
so that I could keep her embodied while I was
Yeah.
watching this procedure. And so I could keep that attachment to her humanity. And this was all going around at the same time when I was observing, the anesthesiologist and the reproductive endocrinologist performing the surgery and the nurses and all this stuff was going on in the room at the same time. And they're counting these eggs as they're coming out of her body. And the eggs, they would go, they'd be suctioned out of her ovary and then go through this tube. And in this particular clinic, the tube kind of it seemed like it went under the floor and then back into
Oh,
the embryology lab, which was directly connected. It was really strange.
yeah.
And the embryologist counted the eggs as they
Yeah.
arrived and then finally got to 48 eggs, which is
Oh
a
my. That's a lot.
substantial
Yeah.
number of eggs. It's way more. It's at least double what they say they're trying to get.
Yeah.
And that kind of really hit home for me. And that, wow, sure, you can't necessarily control how a donor is going to respond to the medications always,
Mm.
but the fact that so many eggs were retrieved from her body and that I just felt like, it just felt like she was producing these products and
Yeah.
it didn't feel really, later on in that chapter, I talk about this intended parent who has frozen embryos created with her husband's sperm and a donor's egg.
Yeah.
And I was in that operating room or that procedure room as well. And seeing the attention and the love and the care that the recipient got, not
Really.
only from her husband who was in the room with her, but
Mhm.
also all the staff and the nurses and the doctor,
Mhm.
versus seeing the sort of matter of fact treatment that Josephina had, I
Mhm.
saw this huge dichotomy in care.
Yeah.
And it's not like Josephina necessarily got bad care, but she
Yeah.
did get attentive care that the recipient parent got. And
Wow.
so I just saw this huge juxtaposition between, you know, donors often tell me I don't feel like I'm the real patient. And that day in those two scenes, I could see tangibly exactly why donors don't feel like they're treated like the real patient.
Hmm.
And that's what that really drove home for me.
Yeah. And then you had the moment yourself, well, where you were trying to stay connected to her humanity. So you can see it almost like it's like you had the ability, you fell into that for a minute of this, medical procedure where we're getting these eggs and she's a source of eggs and not a person. And you had to fight hard not to do that. And you can imagine if they're doing that every day,
Right.
or every week
Very
retrieving
well.
eggs, then it is going to just become like, yeah, like a factory.
It's
So,
not every day. I mean, it's daily, about 5 or 6 donors back to back at a time in most clinics. So you might have a procedure scheduled for, like, one clinic I observed in, they had like 3 or 4 donors at 6 a.m., 6:30, 7, and they
mm,
had a whole line of beds. Most of these,
oh,
and they just kind of churn them out. One comes out to the recovery bed, another one goes into the procedure room, goes out to the recovery bed. So it's like a constant assembly line of
oh my
donors
gosh.
being churned through these procedure rooms and out
Oh,
to the
that's a
recovery room.
visual. Is that
Yeah,
in Spain or
that's
is
here
that
too.
here
That's
too
here
in the
too.
US?
I've been in some clinics here in the US where I've seen like a lineup of about 8 to 10 beds. Not all of them are always, occupied all the time, but it is like you wheel them in, you wheel them out, and you wheel them to the car. Wheel them in, wheel them out, wheel them to the car. And there could be behind a curtain, you know, 5 or 6 donors in a line, all going through recovery at the same time, but at different stages of recovery.
Yeah.
So, yeah.
And did you see that women that were at socioeconomic disadvantage were more commonly egg donors? I mean, that's probably
Yeah,
hard to tell.
It depends. So in the United States, the egg donors are often, students or just out of school. Many of them have student loan or other education debt.
Mhm.
The education levels vary, but usually they're college educated and usually at least temporarily financially struggling and using egg donation as a means to overcome debt, predominantly education debt, sometimes credit card debt as well.
Yeah.
In Spain, it's a bit of a different group. In Spain, it might be more common to have donors or women who are like a cashier at Zara or a waitress or sometimes students, yes, but not necessarily students. That's sort of the image, but it's often working women, young mothers who want to stay at home with their children and help support their families, using egg donation as a way to provide income for the family. In Spain, I also saw a lot of South American immigrant women providing eggs, but specific South American women. So, for example, women from Argentina who tend to be more fair, women from Venezuela potentially. So the features in Spain, that because they match, the donor recipient matching is in the hands of the clinical professionals.
Yeah, they use like a program, don't they? A phenotype.
Yeah, they use what's called like PhenoMatch or OvoMatch or whatever. It's a facial biometric system.
Yeah.
And they also do blood type matching and other phenotypic characteristics. And in the United States, obviously, people choose their own donors. In Spain, people cannot choose their own donors. It's all in the hands of medical professionals. So in Spain, they're looking for donors that predominantly meet the phenotype of the broader European market. So it's going to be fair and so on. But so the donors in Spain tend to phenotypically match the broader Europe. And that's kind of like narrowly defined in terms of, skin color, hair color, et cetera. But they don't have the same education levels as US donors have.
Okay.
And they don't have the university debt that US donors have. Excuse me.
Okay. Yeah. Yeah.
So, for example, one donor was from Colombia, and her parents sent her to Spain. In Spain, she donated eggs so she could bring her sister over. Then her sister was going to donate eggs to bring the parents over. And so they were migrating from Colombia to Spain using the money from egg donation.
Wow. Okay, got it. Yeah.
Also, there were a lot of Ukrainian egg donors that I saw that, right after, obviously, the war in Ukraine completely upset their lives. Many of them migrated to Spain. They're trying to rebuild their lives in Spain with, not much money, not much resources. And so they turned to egg donation in order to be able to do that. Yeah. In Spain, the compensation is only 1,300 euros and it's kind of capped, unlike the United States.
Okay.
And so what you're getting is a group of women for whom 1,300 euros will make a difference.
Yeah.
So in the United States, it's, 10,000 and up. So different practice.
And they've been told often by doctors that donating their eggs shouldn't affect their health, or it should not affect their future fertility. And we don't really have anything that proves that. We don't have any information. And so has that been really a goal of yours, is to get that information so you're really you're allowing them to give true informed consent about donating their eggs?
Right. So just to talk a little bit about the study to help fill in those details. In the study, I conducted surveys with over 1,000 donors including about 170 from Spain, and did interviews with about 300 donors, 70 or so from Spain. And what I wanted to find out was the degree to which like their experiences match their expectations based upon what they were told in the quantitative data. So most of the donors have been told by the doctors that the risks were less than 1%. And this is for immediate complications.
What does that mean?
Right.
Less than 1%. Like, yeah.
Well, let me explain that. So,
yeah.
so this meant for immediate complications, doctors pretty much, and clinic websites and so on say it's low risk, less than 1% of donors have problems, etc. Well, and they're usually meaning things with that 1%, they're usually meaning things like severe ovarian hyperstimulation syndrome.
Okay. Yeah. And we talked about that in the last podcast. If you didn't hear about that, we'll go ahead. You can explain that's a complication from egg donation, and I'll let you explain what can happen with that.
Yeah. So in my quantitative data, about 12% of donors had severe ovarian hyperstimulation syndrome or worse. And this is when after the retrieval, your body starts to fill up with fluid, with ascites, and they can get so bad you can gain maybe 10, 20 pounds of fluid weight, and it presses on your lungs. You can't breathe. Your kidneys can shut down in this worst case scenario. It could lead to, heart attacks, etc. In the most critical sense. So again, about 11.5% or close to 12% of the donors in my study had ovarian hyperstimulation syndrome bad enough, severe enough to have to go and have fluid drained from their bodies. One donor, as they were draining fluid, one of her lungs collapsed.
My gosh.
Right. So, and then out of that 12%, a 1% of them had complications so bad that they almost died. So I have one that had a pulmonary embolism, another that had gone into cardiac arrest that had to be resuscitated, another that had a blood clot on her kidney and had to be on kidney medications for the next year and a half.
Oh my!
And so these kinds of things.
And this is all from OHSS, ovarian hyperstimulation syndrome.
Yes. And so 12% of the women in my study had that complication. Now, that doesn't necessarily mean that globally, across the US, whatever, every donor is going to have, that this 12% of donors across the world have this complication. I can't say that necessarily that the 1,000 donors I interviewed and surveyed are a representative sample of the global scenario.
Yeah.
But it's still significant.
It's significant.
Now that's only one type of complication that can happen post-donation. Another type is ovarian torsion, where your ovary twists in your body. And I think between 7 and 9% of the donors in my study had ovarian torsion. I mean, it was a lot higher than that 1%. So if you start to add up all these possible immediate complications, it's much higher than the 1% that they're being told.
Are they being treated by the same fertility doctor, or are they going to a different provider to get treatment for this?
Sometimes yes, sometimes no. So sometimes they're treated, internally in the clinic because, the clinics don't really want those numbers getting out. It doesn't necessarily, it's not going to be helping clinical practice, right? So some clinics try to keep it internally, especially if something really disastrous happens, like a donor ends up in a coma, which does happen. It's rare, but it can happen. And yet other clinics say, well, you've got a card, go to the emergency room. And so, the donor might have temporary, insurance through their contract and go to the emergency room, but then that is never counted as obviously her having OHSS. So the real information that donors should be given would be more factual would be that, it can happen between 1 and 13% of the time, but we don't know,
Yeah.
So,
so why aren't they counted with they get when you said a card, like a credit card, who's paying for it? Are they
an insurance card? It's an
insurance card, and then it's not counted as, why would it not be counted as OHSS or a complication?
We're not keeping track of that in the United States.
Okay, got it.
There's no system for following up on the donors and the degree to which they experience complications. Okay. Now, in the CDC data and the Center for Disease Control data, there is they are keeping track of OHSS in people who become pregnant, whether with donor eggs or with their own eggs.
The
And
parents, the recipient parents.
exactly. Anybody who has a live birth through donor eggs, they're keeping track of what happens to those women. But they
Okay.
keep telling donors, because you're not becoming pregnant, you're at lower risk. Well, the fact is that donors have other risk factors for OHSS, like low
Mhm.
BMI, your low body weight, you're smaller, whatever, you're going to be at higher risk. High
Mhm.
fertility, they're being chosen and selected because they have high fertility,
Mhm.
because they have a lot of eggs and a lot of healthy eggs. So
Mhm.
high fertility can be another risk factor. PCOS, many donors have polycystic ovaries and they don't know it. So
Yeah.
that's a risk factor. And they're also given oftentimes the same, if not higher dosages of hormones that recipient parents or intended parents are given. So if you have a person who's being treated for infertility who's say 30, 35, 40, their fertility is going to be different than that of a 22-year-old. It's going to affect the two groups differently.
Yeah.
So,
Yeah.
yeah.
Yeah. And then their future fertility.
Mhm.
What about you said these women that have high fertility rates and they're at more of a risk, but also is there a risk of their future fertility being in jeopardy?
Well, that's an interesting question because, again, across the board, what most donors are told and what the industry standard sort of is in terms of thinking about eggs, the
Hmm.
eggs that are lost every month. So I commonly hear a physician explain it like this. They say, well, we're not taking more eggs than your body would produce otherwise, because every month your body's losing a lot, X number of eggs, no matter what you do. And so maybe only one comes to maturity, but there's other eggs, sort of the follicles and so on that are just dying off every month, right? And so what they do with the medications is they feed all of the follicles in your ovaries the follicle stimulating hormones to help all those eggs come to maturity. And so it's not taking more eggs than you would normally produce. It's just allowing the ones that are already there to come to maturity to be retrieved. So that's sort of the clinical explanation of how, you know, this functions in a woman's body. And so they say it's not going to reduce your fertility. You're not going to lose more eggs than you would otherwise.
Mm-hmm.
But it's really interesting. And this is just stuff I've been reading recently on ovarian aging. And there's a number of researchers out there that I've been looking into that have been investigating the role of ovarian aging in premature menopause, and have been trying to figure out ways to slow down egg production, monthly egg production, in order to slow down reproductive aging.
Mm-hmm.
And this has me questioning if, in fact, there might be some reason to think
Mm-hmm.
that it could potentially impact, earlier diminished ovarian reserve or earlier menopause. Because if
Mm-hmm.
if there's science, if there's researchers out there trying to expand your fertility
Right.
timeline by reducing eggs lost per month, then why wouldn't that apply to donors and their fertility? If you,
Exactly. Yeah.
yeah,
Yeah. So we don't know. We don't
I
know.
don't know, but
And
yeah,
we talked before, I think, on the podcast about, cases, and we've heard cases of donors that like are in the group. We are don't egg donors
yeah,
that have experienced complications long term, whether it's their
right,
fertility or if it's developing a illness or cancer. And so we still just don't know.
yeah,
And your passion for egg donors, I know that when we have this conversation, I think it's super important to let people know that we're not it's not that we're saying like egg donation shouldn't be done.
right,
I'm not making that call. I'm not judging. I'm not here to talk about whether it should or should not be done, because that's irrelevant. Really, it is here. It's here, and women are donating their eggs all over the world. And so it kind of goes back to like women's health care, and
right.
especially like reproductive health care, which we know is something that's neglected a lot for
Yeah.
women, and also treated differently.
Mhm.
So I guess, my question is how do you address that when people say, oh gosh, if you say something bad about egg donation or egg donors, that, you're taking away from this beautiful thing that is help, because I I think that that's where it gets the people's feelings. They're so strong that they think,
Right.
oh gosh, it's all or nothing. What are your thoughts on that?
Well, it's a really challenging tightrope to try to walk, right? So, you know, in the book, I have a lot of donors who've experienced serious reproductive harm having gone through this process. And I have other donors who have had great experiences. And where I ultimately end up is, you know, these are the these are the problems, these are the challenges. The lack of informed consent is a challenge. The taking too many eggs per cycle is a problem. The complications are a problem, et cetera, et cetera. Sometimes lack of industry transparency can be a problem. And yes, there are all these problems along the way of things that need to change.
Mm-hmm.
And so where I end up at is though, okay, given all these challenges, what would be how can we move forward with egg donation in a way that's going to be protective for everyone,
Love it.
including intended parents, including donor conceived kids,
Yes.
and including donors?
Yeah.
Because, you know, I imagine any intended parent that's using an egg donor would not want to see them be harmed.
For
Those
sure.
people are helping you, donors are helping you with a very, a very special, people always say special gift. They're helping you have a child.
Mhm.
You know, they're emotionally invested in your success at becoming a parent. And so, as a parent, as an intended parent, there are things people can do to help look out for their donors. You
Mhm.
know, you really don't want to, have a donor have an HCG trigger shot if she's got 30 eggs, right? So, I mean, there's a number of things.
Yeah.
Follow up on donor care, things like that. And
Mhm.
and what I really want to see come out of this book is egg donors having access to more information and being able to provide truly informed consent because they understand all the risks and they understand the benefits, and they've come to a point where for them the benefits outweigh the risks, whatever those might be. And I think especially because these are really often very young women, I've
Yeah.
got some that were 17, 18.
Yeah.
I would
Yeah.
like to see the age range come up higher to maybe 21, 22, but there are things that people can do to make sure that their donors receive better care.
Yeah.
Yeah.
And also, f- a couple things. One, recipient parents, I can see like, this is a person who's helping you have a child. So of course you care on some level and you can advocate for them, just like Dr.
Yeah.
Tober said, is advocate for your donor and ask them how they're being treated. If anything, that's what we can start with, right? Because then
Yeah.
that gets the attention of the providers that, hey, we care about this. And yeah, and second of all, I want to say that even if it feels like it's a moment in time and that this is she's overstimulated, she's better now, everything's okay. I think it's important for parents to think about long term, because eventually, and I'm a mom through adoption, and eventually, my daughter's 20 now. Eventually, you get past the baby stage. You get past, they grow up. They might want to meet the donor. They might want to meet their birth family. In my daughter's case, I'm more than likely going to find out the story, and it's going to become relevant again. So I would like people to think long term, that this is something that is you're investing in. It's like for the rest of your life. It's your child, and it's the story they're going to hear someday, and they may find out what happened.
Right.
So anything you can do to make a difference now is huge.
Right. Yeah. And this, it's interesting because most of the donors I've talked to, whether in the US or in Spain, most are actually open to being identified at some point in the process.
Yeah.
Some donors would be fine being identified very early in the process.
Mhm.
Excuse me. And some donors, maybe when the child reaches 18.
Yeah. Yeah. And I found the
When-
same thing.
yeah, or whenever. And so being open to that and is, considered, for the most part, we've seen this best interest of the child to know, early and often, A, how they were conceived,
Yeah.
and B, to have some access to the donor available in case they want more information at some point.
Yeah.
Uh, and then secondly, another thing that I think throws a wrench in all of this is
Mhm.
the increased use of frozen and banked eggs, because in those cases
Mhm.
the egg donor is really completely separated from her eggs.
Yeah.
Frozen eggs typically go out in batches of 5 or 6 for about $20,000 a batch. And in those kinds of cases, when people are using egg banks, they're not going to have that kind of one-to-one reciprocity that they
Yeah.
have with a fresh donation cycle or an open or identity donor from the outset.
Yeah.
So,
Yeah.
vitrification or egg freezing has definitely changed the
Hmm.
dynamics between intended parents that use frozen eggs and the donors.
As a counselor for help, recipient parents trying that to have a baby, I prefer a donor that's dedicated to the recipient parents because it gives them more chances. If they want to have more than one child,
Right.
they have more than a higher chance at having siblings that are genetically fully related. So, and otherwise it's a lot, go through. So I've talked about this before. If you're splitting eggs between different families, then those are half siblings in different families. And maybe that first family really wanted a second child that was the same genetically, but they couldn't because the other eggs that were given to other family or sold to other families. So
Right.
that stuff's really kind of frustrating to me to see because
Yeah.
it complicates family matters. It just does. It makes it more complicated.
Yeah.
So the other thing well, first of all, I want to say, trigger warning right now. I'm not much of like, I don't always think that the trigger warnings are necessary, but I do think it is in this one because I want to talk about Jenny in your book. And this one really, I'm giving a trigger warning because it really hit me. It gave me some anxiety. I had to like close the book for a minute. And I think I told you the other day, your book's working me up so much. So, but Jenny was I believe, correct me if I'm wrong, she's really excited about being a donor because she thought she could travel, and this would be great.
Right.
And she could travel to other countries and she could donate and what a kind of a win-win, help a family afford to see the world like she wanted to see the world. And then
Yeah.
things took a turn and
Right.
a pretty drastic turn. So, can you tell us a little bit more about Jenny's story?
Yeah, Jenna, she was
Jenna.
from California. I think she had grown up in Nebraska, but she moved to California in her 20s or whatever. And at first she wanted to do Habitat for Humanity, but then she discovered you have to pay for that. So she decided against that. And then she thought, okay, well, maybe I'll donate my eggs because she knew somebody who was working for an international egg donation agency. And so at first, so she signed up, she got picked to donate eggs for a gay couple from Spain. And they were initially going to go to India, but then India shut down and wouldn't allow access for same-sex couples anymore. So they finally decided on Thailand. And so, Jenna went to Thailand. I guess the couple went to Thailand, but I don't think Jenna ever met them. And she produced about 35 eggs. She also got pretty severe ovarian hyperstimulation syndrome. And as she was waking up from surgery, her cousin took a video of her screaming that she felt like she had been stabbed in her ovaries. And sometimes if the surgeon doesn't have a sort of a delicate technique, he
Yeah.
can actually bruise, the ovaries because if you're too rough,
Mm-hmm.
it can damage the ovaries. But in any case, so she was really uncomfortable then, but recovered, went back home. She was fine. And I interviewed her shortly after that donation. And then about 6 months after I interviewed her, maybe a little longer, maybe 9 months, she called me in hysterics. It turned out that the clinic that she had gone to, it was called All IVF with Dr. Pissett in Thailand. It turns out that there had been a huge scandal involving a Japanese businessman, and the police had raided his Thailand apartment and discovered there were like 13 babies there with a number of surrogates and nannies and so on. And it turned out that this businessman not only had about 13 children in Thailand, but also other children in other parts of Asia, Cambodia, Japan, etc., and at least a total of 20 or so. And they were going to confiscate the children. I think they did for a while. And then, he was questioned as to why he wanted to have so many children when he wasn't even there to parent them. And he said, well, I wanted kids to help me run my business. Well, I don't know who needs to have 20 kids to help you run your business, but in any case, that was what he said. And so Jenna was really distraught and concerned that her eggs might have been, as she said, trafficked. She didn't know if all of her eggs went to the couple that she intended, or if because she had so many, if they were distributed elsewhere.
Yeah.
Given how many she had, I would imagine it would not be unheard of that the couple would have received maybe, a batch of 6 or so made to make embryos with, and the rest probably were distributed. So
Yeah.
she's terrified that there could be children out there somewhere and she has no idea where. She has no idea if she will ever, if they're okay, if she will ever be able to see them, or if they know of her or anything. And so she's really concerned that, you know, something malicious could have happened to the children that her eggs produced. So,
Yeah.
yeah.
And that's the reality of it, is that that is possible. It is
Right.
possible. And so I'm that's why I really prefer known donation. If you can meet the recipients and have a cycle where they get all of your eggs and that they're not allowed to donate them forward if you wish,
Which is
So
what she thought she was doing. She thought she was matched only with that intended parent. She was never told that her eggs were going to be used anywhere else, but it happens all the time.
so
So,
there was no protection, is what you're saying. There's no
right.
contractual protection, there's no legal protection, there's nothing. Once
And
once you've relinquished your eggs, they're gone. They're not yours anymore.
And even if there is a contract, and even if there is legal protection, for example, in the story of Terry Royal in the chapter called Poached, her donor in her agency had a contract that only the one set of recipients would receive her eggs. Well, when she went in for her follow-up appointment with the doctor in Texas, I believe his name was Dr. Allen, discovered that, he said, "Oh, congratulations, you got both your intended parents pregnant." And she's like, well, what do you mean both my intended parents? I chose only one parent, and I have a relationship just with them. I didn't donate eggs to multiple recipients. And that led to the end of Terry Royal's business, because she ended up getting sued by multiple parties and, ended up embroiled in legal matters for, decades to come. It destroyed her business and it destroyed her life.
But not the physicians?
Not the physician. No, he's still practicing. Yeah.
And why is that?
Because there's no accountability, and there's very, you'd have to read it in the chapter, but Terry tried to sue him and didn't go anywhere. I think she opened up a RICO case and all kinds of try to do all kinds of things, but it didn't affect his practice. It only affected hers.
Unbelievable.
The
Unbelievable.
donors sued both of them, but yeah.
So kind of going back full circle to like the beginning, which is like women's reproductive rights, informed consent, treating women medically in responsible ways, and equitable ways, really. One thing that also struck me is that you mentioned early on, I think this was in 92, you said maybe you were at you'll have to tell me where, but I know that they were trying to, I think, pass a law that allowed women to get paid to donate their eggs. And their reasoning was, well, men can donate their sperm. So for equality, women should be able to donate their eggs. But that's a very different process.
Yeah, that was actually a 2013 bill in the state of California, AB 926, that sought to allow women to be able to provide eggs for research purposes and be paid. Because in California at the time, the law was that, because of CIRM, the California Institute for Regenerative Medicine, and conducting embryo research in California, it was passed. We passed a law that said that any eggs that are used for research purposes cannot come from donors who were paid. So those eggs had to be sort of voluntary eggs, which put California researchers behind researchers in some other states like Oregon, for example. So the law sought to change so that people who are providing research eggs could be paid the same rate as donors who are providing eggs for fertility purposes. And so, but yeah, we fought against that bill on the basis that there's a lack of informed consent, so you cannot give informed consent as a research subject. B, that donors providing research eggs, the research isn't on them. So it's not like a normal clinical trial when it's testing the drug on that person and you want to know how it's affecting those people. They just want the materials. They don't want to care
Once
about
again,
the person.
yeah, the product.
Exactly.
Yeah.
And
Hmm.
then C, we hypothesized, or we emphasized that having a research market for donated for paid for eggs and a fertility market could further bifurcate the market in human eggs, where the low-income women and women of color might be funneled off to the research eggs, and other women might be selected for, fertility eggs. Now,
Yeah.
we don't know the degree to which that has happened. I mean, that was sort of our argument for opposing the bill at the time,
Yeah.
but it definitely was something that we raised as a concern. There were things we wanted to see modified in the bill that ended up not getting modified, like we wanted to have
Yeah.
follow-up on donors. And Governor Brown vetoed the bill at the time, but it was passed a few years later by Governor Newsom. So, yeah.
Hmm. And then you, but this, I guess, explanation was what they used.
Equity. They framed it as an equity issue. Yeah. It was so disingenuous because obviously, I'm sorry, but masturbation and
Right.
hormones and surgery are very far apart.
So far apart. They couldn't be more far apart. I mean,
Exactly.
and then
So,
especially after you've described the scene of what they're medically going through, what women are going through medically, and how
yeah.
it's a difficult thing to get eggs out of a woman's body. So
Yeah.
it's odd what an odd choice. And yeah. So that really struck me. And then I think that when it comes down to it, it comes down to like the commodification of
Right.
of eggs. And I think when it becomes a business model and becomes about profit and money, then it changes the way people
Yeah.
behave. And how do you see, what's been your experience? What have you seen that kind of in that theme?
Well, yeah, I mean, eggs are commodities, and eggs are items that are sold. I mean, if you look at the open market in the United States, if you kind of like calculate what donors are paid versus what intended parents pay for eggs versus how, the economic value of just a standard egg from a standard donor, not Ivy League, not Asian, or there's this whole hierarchy in how much people get paid based on their traits. But a standard egg on average is worth about $3,000, right?
One,
So
one.
one egg. So on the open market, right? So if you have a donor who produces 70 eggs versus a donor who produces 20 eggs, you're going to make a hell of a lot more money off that donor who produces 70 eggs, especially when it comes to the frozen egg market, not the directed one-to-one. And so there's a huge impetus for people that are involved in egg freezing and banking and distribution to, more aggressively stimulate donors to get maximum quantities, because maximum quantities enhance profits. And I have several charts again in the book that kind of lay all this out in terms of how this operates globally. But, so if a donor comes in, for example, for her first screening, they do what's called a transvaginal ultrasound to check what's called her resting antral follicle count. Well, what that is sort of, you look at both ovaries, each ovary, and you can kind of tell like how many little follicular sacs there are in each ovary, and get an estimate looking at her hormone levels and so on about how many eggs she's going to produce, right? So there's one case in here with Lisa, who's an agency recruiter, and she explains that, some of her donors come in and you can tell they're going to maybe produce 10 to 20 eggs. And so they'll be directed to the directed donation program, where it's one recipient receiving her eggs. Another donor might come in and you can see, oh, as Lisa says, she's going to be a big producer. So they direct her to the frozen egg program, where her eggs are distributed amongst multiple couples. Each of those donors is paid $7,500.
Yeah.
But the donor who produces 20 eggs is maybe making, $40,000 for the clinic, whereas the person who produces 78 eggs, enhanced by hormonal stimulation, right? This is a doctor's call to do this. If she's producing 78 eggs, that's $240 something thousand dollars. So there's a vast difference in terms of like what the donor produces and how much money a clinic can make, depending upon which kind of clinical model they go by: directed donation, shared donation, or egg banking and distribution to as many recipients as you can. And so this is another thing that most donors don't understand going into it, is that the physician knows, whoever's doing your transvaginal ultrasound and checking your hormone levels, they have a pretty good estimate as to what, how many eggs you're going to produce.
Yeah.
Now, some clinicians will say, okay, because she's probably got polycystic ovaries, she's probably going to produce a lot of eggs. And so I'm going to scale back her medications out of interest to protect her health. We don't want her getting hyperstimulation syndrome, ovarian hyperstimulation syndrome. But other physicians might say, wow, like Lisa said, she's going to be a big producer. And then, she ends up producing a massive amount of eggs, ends up hospitalized, what have you.
Yeah.
And one doctor I interviewed told me that, in clinics where they're producing large quantities of eggs per donor, that is a direct result of what physicians and practices decide to do, and that it's iatrogenic, meaning medical harm caused by the physician. So these are clinical decisions, and people can make the right decisions. People can choose to make the right decisions on behalf of their patients, or they can choose to be greedy and maximize profits. But you can't have both. So
no.
well, I mean, if you're going to be greedy, you're not going to have best practices, right? So
yeah, or you're going to delude yourself, or you're going to make excuses, just like a lot of the doctors that lied and told parents they were using a student physician, and then
it was the doctor.
It was the doctor, or it was somebody else, or it was some employee. They rationalize it.
Exactly, and and there was one donor that I interviewed who also took the survey, and she had really severe ovarian hyperstimulation syndrome afterwards, and a number of other complications after her donation that never resolved. And she sent me her medical records. And she didn't know, she found out later from her own doctor that she had PCOS, polycystic ovaries. Well, because she couldn't figure out why she had, so many complications and so many eggs. Well, and at the top of her medical records, the first doctor who did her stimulation wrote PCOS looking ovaries. So he knew it's right there in black and white. He knew what he was doing to her, and he did it anyway.
Wow, that's unbelievable.
And this just kind of gets me to where we are as women in this country.
Exactly.
And what's happening to us and to our bodies and to our reproductive rights and to our rights to access to information, to informed consent, to policy, evidence-based policy that directly impacts our health and our lives. And just, the degree to which really women in this country, at least how it feels right now, don't get the respect and the rights they deserve and that they've earned. And, wherever one falls on the political spectrum, they're still being shortchanged in terms of what they're entitled to,
Yeah. And I think you have to have empathy. You have to be able to understand that, it could easily be, you could easily be the donor and be mistreated or overstimulated. And I think when the industry, the people in the field try to when they separate the recipient parents from the donors, that's the goal, right? If we can separate them, then they won't see each other as human. They won't have these feelings and thoughts. We can keep it simple. At the end of the day, this is my message to you parents out there, is that more than likely you are going to know this story. You are going to know who the donor is. You are going to know what they went through. The doctor's going to be long gone, maybe on the beach, maybe at a nice resort, right? With the money. And you are going to still have this story to tell your child, and your child and the donor conceived person is going to have to live with this story. So remember that instead of saying, oh, it doesn't matter, or I'm going to put this out of my mind, because that's how if we can get women standing up for women, and we can or a recipient parent, and we can say, I care about my egg donor. And I want to make sure she gets good care.
Right.
That's how we can make a difference. And it's not just going to impact her, the egg donor. It's going to impact you and your child.
Right. So, because, with ancestry testing and so on, chances of donors and donor conceived children, offspring meeting are extremely high. Yeah. So there is no such thing as anonymous donation anymore, especially in the United States, even if you say it's going to be anonymous. So
even the clinics.
Let's start off from a standpoint of transparency and, from both sides, and, which is really the best for kids anyway.
Yeah. Do you have anything else that you'd like to share that we didn't cover?
Well, yeah, I mean, and thinking about in the last chapter of the book, as I mentioned, I I get to a point where after laying out, the good, the bad, and the ugly, so to speak, throughout the rest of the book,
Mm-hmm.
I get to a point of, okay, what would egg donation look like through the lens of reproductive justice? What would it, how, if you bring justice into this equation,
Mm-hmm.
how might things function differently?
Mm-hmm.
And the case that I used for this point, for this, I think I call her, what do I call her? I think Alan, yeah, because I use pseudonyms throughout the book.
Mm-hmm.
Um, Alan, she was a Black woman, and at first she was just going to donate eggs for money, but then she decided to do a freeze and share, so to freeze some of her eggs for herself and share some with the recipients, the intended parents. And it didn't quite work out that way for her initially because she had a low egg count, but she decided that from her framework, especially as a Black woman, especially as coming from ancestors who she knows who don't know their identity or where they came from, coming from, ancestors who were commodified and not wanting to commodify anybody who might be coming from her, born from her eggs, she brings a different perspective to what egg donation could look like if it's done better. And part of that is removing that commodity quality from the egg donation process, removing the financialization of eggs, having it be more intimate and transparent between her and the intended parents. And eventually they became pregnant with her eggs and had a child, and she's met the child several times and they have a great relationship. And she kind of pushed back against the clinic narratives throughout her entire process. People at the clinics kept telling her, "Oh, you're not going to find a Black family who wants to have an open donation."
Mm-hmm.
And her response is, "Well, I'm pretty sure I can find a Black family that shares my values because I grew up in one." And
Yeah.
so she refused to take what everybody was telling her, what the professionals were telling her for granted, and she mapped out her own course.
Love
And I
it.
was really inspired by her story because she didn't need the money, which is the big factor.
Yeah.
It helped her feel more empowered to
Yeah.
think about what kind of egg donation she wanted to participate in and what would work for her, as well as be consistent with her values. And thinking about being consistent with values, that's kind of where I end up in the last chapter is, okay, drawing upon this model, how can we do things better so that donors are harmed less, donors have more access to informed consent, and donors have more access to being involved in the decision-making process in ways that they haven't been before. And also following up donor health over time, because that's, again, something that hasn't been done.
How do we make it better for donors?
Yeah. Yeah. Well, I mean, I think first and foremost, we need an egg donor registry to track donor health so the donors can have informed consent. We need to inform donors that the research that exists, and mine is probably one of the biggest projects, but beyond mine, the research on long-term risks really hasn't been done. So we don't know what the long-term risks are. So donors need to have that information. They need more thorough information on what can possibly go right and what can possibly go wrong throughout the process. And and they need to know that anonymity is no longer a possibility, at least in the United States. In Spain, they still practice anonymity. I don't think it's going to last forever, but that's what they're doing. And so thinking about more ways to be transparent throughout the process, connecting donors and their recipients, having open identity from the outset, and also, intended parents being aware of some of these things too, and taking on some, and I understand that when intended parents are going through this process, it can be a very heavy emotional process, especially for, in heterosexual couples, the recipient mother might be feeling a lot of emotions around not being able to use her own eggs and wanting to have some sort of control over the process because she's already lost control. But at the same time, and maybe even also having fears about the donor, and not being quote unquote real mom.
Absolutely. All the things that write about remake space.
These are all things that we have to validate and understand. And at the same time, once they make a choice to go forward with an egg donor, there are certain things you're going to have to do.
Yeah.
Do things in the best way possible.
That's
It's
right.
not going to get rid of all the problems,
Mhm.
but at least you can try to avoid some of them. And so that's kind of what I lay out in the last chapter.
Yeah, and you said Spain is doing a registry, right?
Spain has a registry,
Mhm.
but it doesn't allow people to connect.
No, but it does research or conduct studies
It
or
so far that hasn't been happening yet,
okay.
but in the Spanish registry, they do know. So, say for example, if a donor has a heritable condition like a heart condition, right? And if the donor conceived offspring start having this genetic disorder or disease, Spain will follow up with the donor,
Okay.
ask for medical testing. Then, if it turns out that she was a carrier of something, they'll flag that donor so she can't donate anymore.
Oh,
And
okay.
then they'll contact all the intended parents that conceived with her eggs and say, "Look, unfortunately, we found out our donor has this, genetic
Yeah.
malady, and your child might have it. You might want to get them tested." And in that way, if you have a young child, you can find out if they have any genetic diseases potentially, and try to, you know,
Hmm.
prevent or at least be aware of those.
It's not happening in the US.
That's not
I
happening in the US.
want to make that clear. Yeah. Yeah.
And in Spain also, they track the number of cycles a donor goes through, or the number of donations, and they track the number of live births and where those live births take place.
Okay.
So they know if a donor has 6 live births in Spain, she can't donate to Spanish people anymore.
Okay.
Some clinics say if they've done 6 donations, period, she has to stop. So a donor can't jump from clinic to clinic because it's all a nationalized system,
Mhm.
and her number is in the system. So any clinic that uses her will, say, okay, we used her for, this cycle. We sent some eggs to this couple in France. We have, another live birth in Spain. We have 2 live births in Italy. And so they know where the eggs go.
Yeah.
We don't have that.
Again, it is not happening in the US. Yeah. That is
Right.
not happening at all. And so donors are donating. I recently heard of someone that donated 12 times.
I
So,
have donors in my study that went as high as 19.
wow, 19.
19 cycles.
That,
Yeah.
wow, that seems very risky to me, but
Yeah.
yeah. And in Spain, what's so curious to me is that they don't allow known donation. So it's like it's illegal. Anonymity is like, isn't it like
It's required. It's mandatory.
it's like
Yeah.
is it a law? Is it
Yes.
it's a
It's
law,
mandatory. It's written in Spanish law. Yeah.
Spanish law? And then I mean, a few years ago, from what I understood, a lot of people in Spain still were not even telling their children that they used a donor.
Right.
That's starting to change.
Well, obviously, among same-sex couples, that's changed. Same-sex couples,
Yeah.
predominantly women who are using sperm donors,
Hmm.
they're obviously always going to be more open, because how else would,
Yeah. Yeah.
I mean, for the most part. I think there's been some leaning towards more openness among Spanish heterosexual couples, but it's still not, it's probably not as much as prevalent as it is here in the United States.
Hmm.
There's a lot of stigma associated with infertility anywhere,
Hmm. Sure.
pretty much. So that desire to remain quiet about it and private is really strong. So that's something that's hard to combat.
I think I told you that I just translated my book into Spanish. So,
Mhm.
and it was actually translated by a lady who is in Spain. Yeah, it's going to be interesting to see how it's received,
Yeah.
given that
Yeah.
current, state of anonymity. And
Yeah, well, and it's interesting because in Spain, there's starting to be some pushback against the anonymity standard, and many in the donor conceived community, especially in the adoption community, especially the stolen babies during the Franco era. There's been donor genetic testing, not donor genetic testing in these other contexts,
Mhm.
and the press is starting to pick up on reasons why anonymity might not be the best policy, and looking at the child's rights to know. And in broader Europe, in the European Union in general, there's more of a drive towards openness
Mhm.
and non-anonymity, and recognizing the rights of the child to have access to information that concerns them.
Mhm.
So while this may be happening in broader Europe, Spain is still kind of sticking to its guns, so to speak, regarding the anonymity standard.
Yeah.
I don't think it's going to last forever, because ancestry testing will get there eventually.
Yeah.
It's not used that frequently yet, but
And yeah, it's just what an interesting, like the differences between Spain and US. It's so interesting. Like they have more
yeah,
regulation, maybe more protections because the donors don't donate as much, but then they have
yeah,
this phenotyping and secrecy and anonymity that's enshrined in law. And it's just, and yet here in the US, we have
mhm,
the ability for known donors, but we don't have any regulation that protects donors from
right,
and doesn't really provide proper informed consent. I guess neither place does for that though, Spain or the US.
right.
So
Yeah, yeah. It was interesting because when I first went to Spain to do this research, it was funded by the National Science Foundation, and one of my hypotheses was that you know things would be better in Spain because of it being more regulated.
yeah,
And in some cases, some things are. The registry is a huge thing. I think it's fantastic they even set something like this up.
yeah,
I would love to see something like that in the United States, but I don't know. There doesn't seem to be a lot of will behind it. Whereas in Spain, it was really driven by the fertility professionals. But the anonymity thing I think is problematic, and I don't think it's gonna be able to hold forever because of advances in technologies. It did seem like because donors are all paid the same in Spain, whereas donors are paid a whole range of compensation based on traits.
mm,
The highest I've heard directly from an agency recruiter was $250,000, but now I've heard into the millions for donor compensation, especially for Asian donors.
mm,
So in Spain, because you remove selection from the intended parents
mm.
and they cannot choose their own donors, it removes that marketing
Yeah,
aspect, that commodification aspect. So on that level, it's more egalitarian in terms of compensation and in terms of donor selection.
mm,
But at the same time, that removes the donor's ability to set her own price for whatever she thinks is worth it to go through the process. So there's no perfect solution. There's only things that could hopefully be improved this way and improved that way. And again, I think arguing for more transparency is important.
yeah. So if you're a recipient parent considering egg donation or have used an egg donor and you're listening and you're thinking, I want to do something, what can I do? Is there something that, I mentioned earlier, if you're going to be using an egg donor, you can ask how they're
Mhm.
how they're being recruited and how they're being treated and the medical protocol. But what about if you have any other ideas about that, and then if someone has already used a donor and has a child?
Yeah, if somebody already has a donor and has used a donor and has a child, I mean, obviously the most important thing that I think would be if you haven't had the conversation already, have the conversation about being transparent about how they were conceived and seeing what you can do to if they want to find their donor, seeing what you can do to help them facilitate that contact. And I think from what I see on most of the social media groups and so on, I think that happens a lot, that people do try to, you know, help fill in the blanks for their donor conceived child to the degree that they're able.
Mhm.
And if you're about to about to use an egg donor, just have, sit down with yourself and have some conversations and gather information about, you know, looking at things from the egg donor side
Mhm.
and looking at, and yes, I understand people will already have a lot of emotion around using an egg donor. I get that. But at the same time, when we're involving other people in our something that's so personal, and something that's so intimate, I think it's important to consider what they might be going through, especially because it's going to be a younger woman, maybe even a college student, and think about yourself in those years when you were 20, 21, 18, needing money, and think about what you might be able to do to make the process better for them
Mm.
as well as for yourself. And I think trying to push against anonymous donation is one of those things,
Yeah.
and being and helping and trying to think about what you might be able to do, to look out for the donors. Like, for example, I've heard some doctors say that even though there's no difference between a Lupron trigger and an HCG trigger in terms of egg quality, although some might argue there is, intended parents might think that the egg quality is going to be better with an HCG trigger. Well, an HCG trigger shot also increases the likelihood that a donor will get ovarian hyperstimulation syndrome, especially if she has, say, 25 to 30 eggs or more. So just a small thing a person can do is, rather than try to advocate for making sure your donor has an HCG trigger, which I've heard many intended parents have done, advocate for them to have a Lupron trigger. It's not going to make any difference in their egg quality, but it sure will help prevent them from getting OHSS. So that would be one small thing that they could do that would just make things easier on the donor's body.
Okay. That's helpful. Yeah.
Yeah.
Anything else that you would want people to know just from, like I want to say, like, it's really pick up the book and get the book. I know it's hard. A lot of what we're talking about is so hard. I get that. But it's opening, and it's going to make such a difference. I think the more we know about what's happening, because we can make it better. We can make this process so much better. And I agree with you about anonymity. I think the more people know each other, you bring that humanity back. And that's just better in the long run. So, but yeah, anything else that you would want to share that like we didn't cover so far in the book?
Yeah, it's hard. There's so much in the bock that we can't cover. I mean,
so much. There's so much. Yeah.
Yeah.
It's
and
really good.
I would just like to add that. I'm sorry.
I just said it's really good. I highly recommend it. But
Thank
I
you.
have highlights. I have my earmarks. I mean, it's just, it's really
what a good student. I would like to give that trigger warning, is that it for an intended parent, and I knew when I wrote this book, it will be at times a difficult book to read. It will be. And I empathize with that, and I understand that. And I hope it's not so difficult to read that people just put it away and don't want to think about it.
Yeah.
And put the blinders on.
Yeah.
Because my sense of things is like, the more information you can have, good or bad, the more you can help prevent the bad, and the more that you can do to make sure that you create the best experience for everyone that you possibly can.
Agree.
And so,
and I would say
it wasn't my intention to, alienate intended parents, to make them sad, or make them feel bad or anything like that. But I also had to stay true to what donors told me.
Yeah.
And that's one thing in the book, like, I struggle with, like, for example, on one of those days in Spain, and when I'm going through the clinic rotation with the doctor and I'm seeing patients with her, one woman came in, she was 42. She came in with her husband, delightful couple. They had been trying since she was 28 or so to get pregnant. And they had repeated miscarriage after miscarriage, and some of them late, and they had a lot of trauma. And I was there for her first ultrasound with her pregnancy from a donor egg and her husband's sperm, and just seeing how much joy they had, and her crying, and just the love and support that they had. It was like, okay, I get what this is all for.
Yeah.
Yeah. And I get the immense emotion and everything that comes along with becoming a parent, whatever your pathway to becoming a parent is. But especially in cases where people have experienced infertility for, decades to some degree. And so seeing that situation, seeing that their appointment, and it made me feel really, obviously, very joyful for this couple that they were finally able to achieve that moment that they wouldn't have been able to achieve without an egg donor. And at the same time, so I was kind of struggling back and forth between what I saw with them and then what I saw, with Josephina or other egg donors who have been harmed. And the story is both, the story is both. Yes. And it's not an all, oh, this is such a wonderful thing. Yeah. It is, and it isn't. Yeah. And it's complicated. And I think we have to, especially, we just have to embrace the complexity and figure out how to unwind that to make it a little less problematic for those who go through it.
Yeah, absolutely. And that's how we make meaning out of our experiences and what we go through too, our own heartache and loss and grief, and other people's heartache and loss and grief. We make meaning of it, out of it by, when we're ready, is like giving back and telling stories and helping others and trying to make this better, because it can be better. It really can be.
Yeah.
And like you've shared
Yeah.
ways that it can be better. And so, yeah, thank you for being here and sharing this. And again, please go get this economics. You have to just, take breaks, read a little bit, step back, take breaks. I mean, I would love to see this in a college course.
Yeah.
It'd be
Yeah.
incredible, really incredible.
Yeah.
So
I'm teaching it in my classes, but we'll see if other professors start to teach it in theirs, because I think, given how and where they're recruited, I think it would be essential reading for, just about anyone. So
absolutely. Absolutely.
yeah.
And then is there somewhere people can go to learn more about your, like if you're an egg donor and you want to be part of some studies or learn more about the projects you're working on? Is there somewhere they should?
Yeah, I have my dianetober.com website.
Okay.
That's sort of my public facing website with, interviews that I've done. Like I'll post this on my website kind of thing, and articles that I've written, that kind of thing. And I also have my eggdonorresearch.org website,
Okay.
where people who are freezing or donating eggs can get more information. I'm currently not actively recruiting donors because, I just wrote this book and I don't have the funding to continue to recruit people right now. Hopefully if I get more funding, I'll be able to re-engage in active recruiting and start doing more follow-up.
Mm-hmm.
But if somebody has a story that they really, 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 really want to share,
yes,
I will make time to do that. So
yes,
but
that'd be great. Yeah.
If somebody wants to donate $1 million so I can do a 15-year study,
yeah. Yes, absolutely. Yeah, there's
reach out to me.
Good cause. That's right. So many ways you can help. Well, thank you so much for being here, Dr. Tober.
Thank you.
Pleasure.
Thank you.
Thanks for listening, everyone. If you want to get a copy of the Spanish version of 3 Makes Baby, you can get that on Amazon. And don't forget, you can find helpful parenting information and courses, handouts, guides on my website at 3makesbaby.com.